Hello, everybody. Welcome to Riverwood Healthcare Center. And we are indeed hosting this event through the Minnesota Institute for Minimally Invasive Surgery. Over 20 years ago, our minimally invasive surgeons dedicated themselves to the study of surgery done in a special way, a way where we would not have to make large incisions and a way in which people could recover rapidly. In recent years, we've been fortunate to have more progress at our institute. And this institute is shared between two rural hospitals here in Minnesota, Cuyuna Regional Medical Center in Crosby and Riverwood Healthcare Center here in Aitkin. And we're speaking to you today from Riverwood in behalf of many surgeons. I have the honor of showing you 5 surgeons. They're Dr. Howard McAllister, who was a co-founder of the Minnesota Institute, along with me. And then Dr. Timothy Lemire, and then Dr. Sean Roberts. And then just 2 years ago, one of our fellows in training, we have a fellowship here that trains young graduate surgeons in these minimally invasive techniques. Dr. Andrew Lovett came to join us. And I'm introducing him today because he will be our guest speaker, joining me. And he's also heading up our robotic division at the Minnesota Institute. And we have robots both here at Riverwood and at Cuyuna Regional in Crosby. So in behalf of all of these surgeons, welcome. And I'd like to turn the actual slides over to Dr. Lovett, who is with us. Dr. Lovett, can we have you share your screen and your presence?
Yep, the screen should be shared, and thank you for the introduction. If anyone's having any technical difficulties, let me know. So without further ado, let's start talking about what is a hernia. A hernia is a bulge of tissue that occurs typically on the abdominal wall through an opening in the muscles. There's 2 types that we generally talk about. We define them as ventral, meaning abdominal wall, or inguinal, meaning groin hernias. Now, in truth, you can really develop a hernia anywhere, but these are the ones that we see most frequently and that patients will most frequently complain of. These openings in the abdominal wall are sometimes naturally present at birth. Other times they can develop over time through constant straining, or if you've had a surgery before, it does potentially leave a weakness at that area where you can develop a hernia as well. Hernias are extremely common. Approximately 5 million Americans have an abdominal wall hernia, and there's 600,000 groin hernias that are repaired yearly. 500,000 abdominal wall or ventral hernias will be repaired as well. There's many risk factors for hernias, but in general, they occur as you develop older age, people that are male in sex, Caucasian race does seem to be a risk factor, and most importantly, anything that puts a chronic strain on the abdominal wall. Anytime you're putting a lot of pressure on it, that can lead to development of those weak areas. This could be through a chronic cough, chronic constipation, again, any injury to the abdominal wall, whether that was through a surgery or potentially a trauma. We know that smoking actually decreases the strength of some of your connective tissue. And this can lead to those weaknesses and bulges as well. Hernias do tend to run in families. We know that there's trouble with the connective tissue that leads to those weak areas, and that can be passed down from generation to generation. And certainly anyone that's had a hernia before is at risk of developing further hernias down the line, again, likely due to chronic conditions which caused the hernia initially. So how can someone tell if they have a hernia? As I mentioned, the most common symptom is a bulging of the skin. In the groin, this can also lead to discomfort or tenderness, especially after long days of standing or doing any heavy work. Same with the abdominal wall, a generalized discomfort or swelling. Pain, interestingly, is actually a less frequent symptom, although we do see it from time to time. In pain in the abdomen, the pelvis, or the groin, especially if accompanied by a bulge, is certainly indicative of a hernia. Ultimately, though, the best way to tell if you have a hernia is to have an exam by an experienced physician, and they'll be able to put together your symptoms with the exam and potentially even some additional imaging type studies to definitively tell you whether you have a hernia or not. There's another special type of hernia I would like to talk about briefly. This is called a hiatal hernia. The hiatus is an area in the diaphragm that's a natural opening for our esophagus. The stomach and esophagus meet at this junction, and through the combination of the diaphragm and a small muscle in the esophagus, a valve is created to keep acid down in the stomach where it should be. In many people, this natural opening slightly expands, and this disrupts this natural barrier to acid. Common symptoms from this include heartburn, chest pain, and potentially trouble swallowing. Sometimes we can see these hernias become quite massive, and much of the stomach can be encompassed in one of them. Most people ask, so what if I have a hernia? Are there any risks to it? Well, I'll tell you that hernias do become larger over time. Unfortunately, there's no exercise or physical therapy that can cure or stall the progression of a hernia. And as they become larger, they become more symptomatic. And that's generally how people present. Occasionally, if the hernia has any potential for bowel to be caught in it, that bowel can be caught and it can actually, unfortunately, be twisted off. This can lead to situations where we need to do emergency surgery to save someone's life. Again, this is not a typical presentation. Typically, someone develops a bulge. It becomes bigger and more symptomatic over time, and we're able to see them in the office and fix it under elective, ideal scenarios. But occasionally, we do have to do emergency surgery if the intestine becomes trapped. In that regard, the question becomes, do you need to have your hernia repaired? And of course, this is something that's been studied many times over. And the general consensus at this point is yes. This is a study that was done at the Veterans Administration hospitals. And it actually was a great study that took course over about 10 years. And the details of it may not be important, but the most important thing to realize is that at the start of the study, they put people into two groups. One group got surgery right away, and the second group had what we call watchful waiting, where they would have a frequent exam by a medical practitioner. They would log their symptoms. And initially, the groups were about split. The people that had surgery were doing quite well, and the people that didn't have surgery were doing quite well. However, as they followed the people that did not have surgery over the course of 10 years, almost 70% of them eventually needed surgery. And if that study's followed out even further, you'll see that almost everyone with an inguinal hernia or groin hernia does end up having surgery on it at some point. Now, if you look a little bit at this slide at the very bottom, you'll see that the older people ended up having the hernia repair at an even higher rate than younger people. So our typical older Caucasian male is very likely to need their hernia repaired at some point. And we do encourage people to have it repaired sooner rather than later on an elective basis, because we know that the outcomes are so great, patients recover so greatly, and we can save them from having these symptoms that are really bothersome to day-to-day life. Another very frequent question, is mesh for hernia repair safe? And the resounding answer is yes. We see a lot of things on TV, and as I'm sure you're all learning, we need to take most of it with a grain of salt. Hernia repair has been done with mesh for many, many years. The mesh overall is resoundingly safe, and what the benefit of it is that it decreases the chance of that hernia coming back dramatically. Without mesh, hernia recurrence rates for some types can be as high as 50%. With mesh, you're looking at more for inguinal hernias, less than 1%, and for abdominal wall hernias, depending on the specific type, around 5% of the time. Again, mesh has been used for many years. It's very safe. The mesh we use at this institution, we have personally used for many, many years. And we really would not recommend a repair without it, except in very special circumstances. And of course, we're glad to talk about this in further detail in the clinic. So as early as 2008, we did see a couple warnings regarding mesh. These are mostly for what we call urogynecological procedures or bladder issues. We know that hernias are a disease of weak connective tissue, and that simply tightening that weak tissue back together usually results in the hernia coming back. There's been numerous studies that study mesh versus non-mesh. And again, much lower chance of that hernia coming back with the mesh. And interestingly, although you see a lot of commercials, the rates of complications are about the same, whether you use mesh or not. And actually, for one of the most devastating complications of hernia repair, which is chronic pain, it's reduced with mesh. One can imagine if we're trying to close a hole in the abdominal wall, without the use of reinforcing mesh, we have to close it extremely tightly. With the mesh, we can potentially close it maybe a little bit looser, use that mesh to back up and support the repair, and the chance of chronic pain is lower. Again, there are rare situations that call for a hernia repair without mesh, and your surgeon will help to direct you in that regard. So what treatment options are there? Again, watchful waiting is a reasonable option for some people, and your surgeon can help you determine that. Open repair, which would be through a larger incision, again, in certain situations, is still the right thing to do. Again, the surgeon will help determine that. But the repairs that we focus on here at MIMIS are laparoscopic repairs and now robotic repairs. These are generally done through small incisions, about the size of your pinky finger in width. And we're able to do almost everything that we once needed to use a very large incision for through 3 small incisions. In particular, we're very interested in robotic assisted repair. The robotic assisted repair brings together the benefits of laparoscopic surgery, the traditional minimally invasive surgery, where we use straight instruments to reach across the abdomen and perform our techniques. With the robotic technology, we have the dexterity of the open techniques, but we're able to do it through small incisions. We are able to see in a 3D 10-time magnified image with extremely good detail. The ergonomics and dexterity are improved because instead of using straight instruments, our instruments now have wrists to them, meaning that we can manipulate them in 360 degrees and use them almost like a small hand. One great benefit of the robotic repair is that we're able to close the hole now. As we mentioned, an abdominal wall hernia is really just a hole in the muscle and connective tissue. With laparoscopic repairs, it was very difficult to actually close this hole because of limitations in dexterity. With the robot, it makes it really quite easy. And by closing this hole, we're able to get a better repair. As I mentioned, we have an extremely detailed view and extremely dexterous instruments. And this, we believe, leads to less operative trauma. And we also have demonstrated that it seems to be leading to less pain for our patients. Patients use less pain medication, both narcotic and non-narcotic, and get back to their daily lives much, much sooner. There has been studies that have shown this as well. This study in particular is from the manufacturer of the robot called Intuitive. And the general gist of the study, if you look in the very light blue, is that pain scores at 1 week, interruption of daily activities, and the time it took from surgery to get to no pain was all quicker with the robotic technique, even as compared to the traditional minimally invasive laparoscopic techniques. Now, whenever we see a study from a manufacturer of something, we have to take that with a grain of salt. We know that they do have a vested interest in that. So what we decided to do is study this on our own. So we have done polls in our patients as they've recovered from inguinal hernia repair. And if you have one with us, you'll fill out this data as well. And what we have seen is that the average days using narcotic pain medication is about 2. But I would draw your attention to this portion of the graph here on the very far left, where many of our patients take no narcotic pain medication or only one day. There's very few that need it for any longer than that. Even above that, we do generally recommend our patients use Tylenol and ibuprofen afterwards. And even those patients only need that on average for about 4 days, with a very good majority of them really not even using it at all. If you look on the right side of the page, you'll see return to activity after inguinal hernia repair and pain scores after inguinal hernia repair. Again, you'll see that days to zero pain in the blue a lot of people just never have any pain because of the way we do the surgery. And then there are some that tail off a little bit and have pain for a couple more days, but in general, people do really, really well. Again, we encourage people to return to their activity right after surgery, even the next day. And you'll see that the vast majority of our patients were able to do that without any problem. With that being said, I'm going to hand the conversation back over to Dr. Paul Severson, and he's going to finish up the slides. And again, we'll be glad to answer any questions that may come up towards the end of the presentation.
Thank you, Dr. Lovett. So my job, thank you, Dr. Lovett, is to talk about complications, the bad things that can happen from having hernia surgery. But I'm very pleased to report to our listeners that even though any surgery may be associated with complications, they're very rare when done with minimally invasive hernia surgery. And we found them to be incredibly rare with our robotic assisted hernia surgery. What kind of things could happen? Well, during the surgery itself, you could have bleeding. There could be an infection that occurs after the surgery within the first week. We could have our patients not be able to pass their urine afterwards. There's been reported bladder injuries that occur because we're working in that space near the bladder. We could also have something maybe go wrong with the patient's heart or one of their other systems. Now, I'm listing all these things, but I should really tell people that with hundreds and hundreds of procedures that we've performed, we really haven't seen this. And we've had zero bleeding complications, infections, urinary retention, very rare with this. I should also mention that in years past, we always had to put Foley catheters. These are into the bladder for patients, and that was routine. We did that for our laparoscopic procedures. We're finding that with the speed and accuracy that we're able to achieve with robotic assisted repairs of the groin hernias, we don't need to do that anymore. So we really don't have to put catheters in. We just simply have the patients void ahead of time before they go to the operating room. When they come back out, they void again, and we can avoid catheters completely. Regarding long-term complications, the things that have been reported in our medical literature for many years that have been plaguing patients and their doctors consist of really persistent groin pain. Somebody coming back into our clinics saying, "Doctor, I still have pain here. I'm not sure what's going on." This has become increasingly rare with our modern robotic assisted techniques. One of the reasons for that is because we no longer need to actually fix our mesh to the abdominal wall. What I mean by that is when a patch of mesh is pressed up against the abdominal wall, we're using a mesh nowadays, which we really like. It's kind of like Velcro. And so we can push it onto the abdominal wall and it will stay there. We don't have to suture it, tack it, staple it in place. A lot of the fixation that we used for mesh in the past was the cause of the pain. So with us being able to eliminate that step, this has really helped our patients recover with minimal pain. The other long-term complication, of course, which is the measure of quality, is does the hernia come back? That's recurrent hernia. Now, nobody is going to be perfect no matter how great the technology is. There can always be a recurrence. But we're more likely to see recurrence when it's a ventral hernia or abdominal wall on the front of your abdomen. When it's in the groin area, it's incredibly rare. So let's go on to the next slide and talk about how the surgery is actually performed. Well, first you've got to come in and talk to your surgeon. let him examine you and decide which technique is going to be most appropriate for your repair. Most repairs, general anesthesia is utilized. If we do robotic assisted or laparoscopic, which is rarely used now that we have the robot, general anesthesia is always utilized. That means you'll be off to sleep completely. There'll be no pain during the procedure. Once you're asleep, the surgeon then inserts a small camera, which allows us to actually see the hernia from the inside. And I'll tell you, that's a beautiful thing to be able to check out the opposite side. So let's say that you're having a groin hernia repaired and you think that you only have a left-sided hernia. Your surgeon will be able to look at the right side at the same time. And if you happen to have a small hernia that's not yet detected, your surgeon can actually repair both at once. In other words, it's kind of like a blue light special. Other small incisions are then placed to allow access for the instruments, which then come through 2 additional small openings. And these little tubes that we place, called trocars, are actually about the size of a small ballpoint pen. That's why it doesn't hurt much afterwards. Now, in most cases, the mesh is placed as Dr. Lovett described. And then after the mesh is placed, the instruments are removed and the CO2 gas, carbon dioxide gas that fills up the abdomen is removed. We place some little tiny absorbable sutures, which cannot be seen. They're underneath the skin, with a little bit of skin glue. No dressings are necessary, and the patient returns to their room and is discharged from the hospital right away. Now, these are some actual photos obtained in our operating rooms. The photo on the left is the actual robotic instruments being placed through the 3 little openings into the abdomen. And the robot looks like a giant machine, but what is actually inside the body is extremely small. Like Dr. Lovett said, it's like a little tiny hand that does the work very gently and very precisely. If you look at the photo on the right side of your screen, you'll see an actual picture of a hole in the abdominal wall. And that is a groin hernia, in this case, a direct inguinal hernia. And that is what has to be repaired or covered with the mesh. If you take a look at how the surgery is performed, we have to take away the lining of the abdomen. The lining of the abdomen is called the peritoneum. And if one would think about where the mesh is placed, this would be like if you had a tire and you had an inner tube in the tire. The inner tube would be peeled away, and then a patch, which is seen on your right, the mesh, would be placed over the hole to patch it, and then the inner tube be placed back into position so that the mesh is never exposed to anything inside the abdomen. It's hidden. So if we take a look at the next slide, it'll show what does this look like after the surgery. Well, if you look on the right, you're going to see a patient with a traditional bilateral, meaning both sides, groin hernia repair. There's 2 incisions that's done very nicely. Doesn't look too bad, but they're painful, and the patient will frequently take maybe a week before they can hardly stand up straight, have quite a bit of pain, and they will have to protect it with at least 6 weeks of not lifting and modified activity. Now, if you look at the left side of your screen, this would be a patient who had had a robotic repair on both sides of their groin, same way, and there'd be 3 scars. One would be hidden at the belly button. Right now, it looks a little bruised because it's right after the surgery, but that will fade away and the wound will be completely hidden inside the belly button. And the 2 other small little wounds on the side will heal so that they're almost imperceptible. So what can I expect after I've had my surgery? Well, immediately after the surgery, you're taken to the recovery area. You're monitored for approximately an hour, maybe 2. And from there, you can go home. If there's a complex procedure on the front of the abdomen, you might need to stay overnight. All of our groin hernias, small like umbilical or belly button hernias, they go home the same day. Now, it's normal to be a little bit sore, but most of the time, our patients now don't use any narcotics. They'll simply use what they have at home: ibuprofen, naproxen or Aleve, Tylenol, any of these things that you have in the kitchen cabinet, they might work just fine. Stronger pain medications are offered, but in very limited quantities. It's not really necessary past the first day or two. Now, you're encouraged to talk to your surgeon about how much activity can be resumed and how quickly. There may be some lifting limitations applied, and the reason for that is we want your mesh to actually be incorporated into your body so it doesn't shift or move. Actually, you're probably not going to hurt anything by lifting something, because you're just simply going to push the mesh against your abdominal wall tighter, which is not really a problem. But please talk to your surgeon about when they will allow you to fully lift. Usually that's within 2 weeks of your surgery. So why should you choose to go to the Minnesota Institute for Minimally Invasive Surgery, or as we say, MIMIS? Well, we've had actually almost 30 years now of minimally invasive techniques, but over 21 years now where we actually became an institute and dedicated ourselves as surgeons to achieving minimally invasive surgery in the safe and most proficient way possible. All 5 of our surgeons have extensive experience in minimally invasive techniques. We have a fellowship in minimally invasive surgery where we teach these techniques to graduate surgeons. Around the country, there's only 140 places where young surgeons can be trained experts. And in our state, there's only 2, the Mayo Clinic and MIMIS. We use the newest and latest technology that is humanly possible. We are involved actually with the trials and research to develop new techniques. With our fellowship, this is what we do. So in behalf of all of the 5 surgeons who are faculty and perform these surgeries, I would encourage you to consider coming to MIMIS for your surgery. At this point, I'd like to field some questions, and we've got some questions coming in. I'm gonna ask Dr. Lovett if he can answer some of these. Dr. Lovett, a patient said that she has a lump in her groin and also a belly button hernia at the same time. Would the recovery time be longer after having both of these repaired together?
In general, I would say no. The belly button hernias tend to be on the smaller side, and we can use the same port positions to fix both at the same time. Sometimes we can even, depending on the size of the belly button hernia, put a port right through that and then close it tightly with suture on the way out. If it is a larger hernia, we may require 1 or 2 additional ports. However, that really doesn't add much to recovery. If it's a very large hernia, the one thing that might change is that there may be some very limited lifting restrictions. As Dr. Stevenson mentioned, we do want that mesh to scar into place a little bit and heal before we really let people lift a lot. Again, we're typically looking at 1 to 2 weeks. For groin hernias in particular, I don't personally put any limitations on. I think patients are fine to use pain as their guide and really get back to their normal activities even the next day. I'm not sure how you feel on that, Dr. Stevenson.
I would agree. Different surgeons feel differently. Some would like to have their patients take it easy until they believe the mesh is incorporated into their human tissues. And that can be, 1 to 2 weeks. Certainly by 2 weeks, there's everything seems to be getting solid. But I, like you, feel that with our current mesh and the way we use it, I don't think it's going to move. So, and plus we use a large sheet of mesh right now, very much like covering a small hole in a bike tire with a large patch. So it's very safe. When you get your car, your bike fixed, you just drive it away. And that's kind of the way hernia surgery is today. You can get up and get going almost immediately. I have a similar question that maybe you can clarify. How long might a person who has a physically active construction job, in other words, a lot of heavy lifting, have to be off of work if the hernia repair was performed robotically with mesh?
Again, there is a slight difference in the inguinal or groin hernias versus abdominal wall hernias. Of course, most workplaces will allow for some limitations to activity. And for a very large abdominal wall hernia, I might want someone to lift less than 30 pounds for up to 6 weeks. Again, that's a very large hernia, and mileage will vary depending on exactly how the patient presents. If it's a groin hernia, it's really a different story. Oftentimes we'll repair these on Friday, and I'll encourage people to get back to work in some regard by Monday. Patients may want to consider being cautious. It certainly is not out of the question for someone with a very physical job like that to take a week off from work. Generally, they tell me, hey, I could have gone back to work earlier, but it was okay. But if someone's very motivated and really needs to and wants to get back to work, I'm fine with them going back to it really the next day. It's a conversation we need to have with the patients, and each person's individual timeline will vary. Certainly, as we mentioned, most of these hernias aren't emergencies. And if someone per se works construction, obviously the summer is going to be their busiest time. And I might tell them if the hernia is not really all that bothersome to them, or if they think they can get through the summer, that's perfectly reasonable. And then come see us in the fall or early winter, and we'll get that repaired for you at a time that's convenient for you. We really want you to have the best experience possible.
Very good. There's another really pertinent question to this recent COVID-19 pandemic. How many days in advance of the surgery do you need at Riverwood to get tested for this virus, COVID-19, to make sure it's okay for surgery to proceed?
In general, as long as the patient's not displaying any symptoms, we can test them the day before surgery. Sometimes with cases on Mondays, that would vary just a little bit. But we do have the rapid testing here available at Riverwood. The facility's really done a phenomenal job managing the COVID situation. Our staff is protected, our surgeons are protected, and most importantly, our patients are incredibly protected. We all have the most advanced personal protection equipment, and our testing has really been far and above anything else that's around. We're able to test people rapidly, and that, again, limits their time off from work and away from family. Because when people do get tested, we do like them to quarantine. Of course, you can imagine if you got tested, 6-7 days earlier, and then we're out and about for that entire week after the test resulted, there is the potential there for having a positive exposure. So anytime we can limit that amount of quarantine, which we can here at Riverwood with the rapid test, that's a real benefit to our patients. And again, it's all about us getting you back to your normal life quickly.
Yeah, those are great comments. I just have to say that it is such a pleasure being a surgeon here at Riverwood. We're very fortunate. Who knew that we would have no deaths? That after 3 months that we would only have a total of 13 cases in the entire county. We very rarely have a patient in the hospital. There's been one COVID positive patient the last month. So, and most of the time these patients are actually, quarantined at home and not even in the hospital. Occasionally we'll have people that come in with a respiratory illness. Most of these patients have actually not developed COVID. They've had some other illness. So we're really fortunate to be in an area where there just isn't a lot of experience. Now, that being said, could this get worse this summer or maybe? But we're also fortunate in that in our state, every day now, we're seeing a falling number of COVID-19 patients being diagnosed, even though we're doing 13,000 tests on the average in the state. Yesterday, 300 some patients were positive. That's dropping every day. The number of patients in ICUs, which are not anywhere near us, there's no ICU patients here in rural Minnesota, but in the big city, there are, but that's falling every day. And so people are starting to feel like we're getting over this. But the thing that I want people to know, and I've been on the radio trying to encourage people to say, this is actually a very safe time for you to come in and see your doctor and see your specialist, the surgical specialist, if you're considering hernia surgery, because everybody's so protected. We've never been this protected. All of the healthcare workers, masks are put on. We have you come into a whole separate area of the hospital. On the far end of the hospital, the Michael Ryan Support Service Wing, that's for the surgical patients only. So there's no mixing with other patients. You come in, you have your surgery, you go home. So I believe that we're performing surgery as safely as we ever have before. And I don't think it's important for people to have to wait. We don't know what the fall will bring. And right now, this is a great time. So I would encourage people to come in, get it checked out, get it taken care of. Let me see if there's any other questions that we have coming in.
I do see one question here from one of our participants. It's why would there be cardiac problems after surgery? And that's a very reasonable question. We did mention that. The surgeries themselves are not going to cause cardiac problems. However, as Dr. Severson mentioned, we do require general anesthesia, which means you go all the way to sleep with a breathing tube, both for your comfort and also for us to have enough room in the abdominal cavity to work. And any cardiac problems or lung problems that might develop would generally be secondary to the anesthesia. Now, before any type of surgery like that, you'll visit with a primary care doctor, either yours or are glad to have you set up with one. And they would assess you very carefully for any potential cardiac or lung risk to really limit that chance.
Yes, I'm going to have one final question here, and that has to do with can a patient have a virtual appointment for, let's say they think they have a hernia? Will a virtual appointment, and maybe Dr. Levitt, you could explain a little bit about how we approach these so-called virtual visits, what that is and how that works.
Sure. The virtual visits are very similar to what you all are doing right now. It's a Zoom visit that we try to do with every patient. Sometimes technology doesn't allow that, and we can chat on the phone. But in general, Zoom is really a great platform for us to chat with you. Now, for hernias, certainly the exam is important, but we can get a general idea about your condition from chatting with you over the phone and you describing your symptoms, period. In most cases, someone has had a recent CAT scan that we can evaluate. We can go over that via screen sharing, much like we're sharing our PowerPoint. And that's true especially for the larger abdominal wall hernias. So in some cases, we can potentially meet with you virtually and maybe even schedule a surgery after that. But in a lot of cases, we do really require you to come in at some point for us to examine you. Now, me personally, if you have a very good history, you tell me that you have a bulge in your groin that goes in and out, maybe you can even show it to me via the Zoom visit. I would be willing to have you come in for surgery, do the exam that morning, and then confirm on exam everything that we talked about and move forward with the surgery. Other surgeons might want to definitely see you in clinic first. I think it's very reasonable either way. Certainly if there's any question, then we'll see you in clinic first. We can do a lot of things virtually, but sometimes we really just need to lay hands on the situation.
That's great. I want to encourage everybody, if they want to come to Riverwood to one of the MIMUS surgeons to have this checked out, there's a number you can call, and you should be able to get an actual human being answer you, not a computer. And that number is 218-927-5566. And also we encourage you to look on the website. This webinar will be posted, and there's also other video links for you to follow to learn more about this. I want to thank everybody for tuning in today, and we hope that you will stay healthy and stay safe. Thank you.
Thank you all.